Hello everyone. So today we're going to be starting to talk about cardiovascular disease, drugs that treat cardiovascular disease, and atherosclerosis. So cardiovascular disease refers to any diseases of the heart and blood vessels, including hypertension, which is high blood pressure, angina pectoris, which is really not a disease itself, but symptoms that develop usually due to atherosclerosis or narrowing of the blood vessels and arteries, coronary artery disease, cerebrovascular accident, CVA or stroke, congestive heart failure, and myocardial infarction, also known as an acute coronary syndrome or heart attack. So let's take a closer look at atherosclerosis. Atherosclerosis is the #1 cause of death in the United States, leading to heart attack and stroke. So it's basically a condition in which patchy deposits of fatty material, usually cholesterol, develop in the walls of arteries. And this leads to a reduced or blocked blood flow. It can also lead to blood clots. So initially, when the body senses these fatty deposits developing in the interior wall of the artery itself, it almost views it as an infection. And it ends up sending these macrophages, which is part of our immune response, to actually eat up the fatty deposit. So the macrophages do end up eating the cholesterol of these fatty deposits that are forming within our arteries, and then they begin to look like foam, and because they get all filled with fat and like bubbly fat, and now they're called foam cells. So macrophages, which have eaten up that cholesterol, yum 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 yum, delicious, are now known as foam cells. And unfortunately, these foam cells, instead of getting rid of the cholesterol, end up sticking to the inside of the artery. Eventually it becomes covered with an endothelium, and this, we might refer to these as plaques that start to accumulate and narrow the interior lumen of our arteries. So when we decrease the lumen or the inside distance of our arteries, this decreases blood flow to tissues, which results in a lowered oxygen amount being received by the tissues. And you can see, right, that might not be a good thing if it's to your heart or to your brain. This decrease in the size of the lumen of our vessels also results, right, so now the blood that's passing through the vessels, it's harder for the heart to push the blood through these narrowed vessels. So that's known as increasing the total peripheral resistance. So the heart has to work really hard, and by that decreasing the total peripheral resistance of our arteries, that narrowing results in our blood pressure increasing. Through that, it's not vasoconstriction, the vessels aren't constricting themselves, but essentially they are smaller. So that results in a higher blood pressure. In the heart, having a pump against this really high blood pressure in narrowed arteries, it can get tired after a while, and it can actually go into heart failure. It's really tiring for the heart 24 hours a day to be pushing against a high peripheral resistance. And we can see here the normal blood flow. This is an artery in cross-section, and those plaques are building up there on the interior wall of our arteries. And now look, the blood, right, it's having a hard time getting through because the vessel itself is so narrow. So the other thing with atherosclerosis, right, we can see it can do a lot of things to us, right? It's decreasing our oxygen, maybe to our brain, and that's not good as we get older. It can decrease oxygen to our heart. Now we're having angina symptoms, right? Because our heart muscle isn't getting enough oxygen. It might give us high blood pressure, another bad thing that can also lead to a heart attack. And it can lead us into congestive heart failure. The other thing that can happen as these plaques develop is that it can actually lead to an increase in thrombus formation. And thrombus is an attached blood clot. A lot of times they look like little kites on a string. They're kind of attached to the inside wall of our artery. So thrombus is when it's attached. Embolus is when it's been released and now it's floating through our bloodstream, hunting for a place to make us seriously ill or kill us. Bad, bad, bad thing. So how does this happen? How do these clots form because of the plaque? Well, let's take a look. Let's take a look at a normal clotting process. So in a normal clotting process, so a blood vessel may be cut or injured. So what happens is platelets begin to attach to this roughened area. Platelets are designed to detect a roughened area. And when you have an injury, the platelets will begin to stick to this area. And once the platelets stick to this area, they release something called platelet factor, which basically triggers that whole clotting cascade. And at the end result, a fibrin clot is made, and the fibrin clot almost looks like a spider web. And it's made of platelets and blood and fibrin. And this is a good thing, like if you've cut yourself, because you don't want to bleed to death. So it's a good thing that we have some clotting that takes place. Now, over time, this injured vessel will begin to heal. And the healed wall will release something called TPA, which is tissue plasminogen activator. And this TPA converts plasminogen to plasmin in our blood, and it's the plasmin that dissolves the clot. All right? So what difference does that make for us, right? Well, this clotting is a good thing. So I said earlier that those platelets, right, they're looking for kind of rough spots to attach to. And guess what plaque is? Inside our vessels. It's a rough spot. So over time, right, we're going to start getting platelets to attach here, and we're going to start that whole clotting cascade, and now we've formed a blood clot. Now the difference is there's no healed wall, right? The healed wall of our vessel releases that plasminogen that converts, it releases TPA, which converts that plasminogen to plasmin, breaks down the clot. We have no opportunity to break down that clot, and over time the clot may release, and if it's in an artery, it can go to our heart, it can go to our brain, causing a heart attack or a stroke. The other thing that can happen with plaques is they can build up to a certain point and they can get really big, and then a chunk of them can break off, go through our circulatory system, end up in our heart or our brain. Now, when we hear things called like the deep vein thrombosis, when we talk about thrombosis in our veins, a lot of times when these travel through our circulatory system into our atria, they end up going to our lungs through our pulmonary artery. And so someone might have a pulmonary embolus caused from a deep vein thrombosis in their leg. So there are a lot of different things. Oh, and I put this slide back in again because look at all that big juicy plaque in there. A chunk of that breaks off. That ends up heading to your brain, and you are in a world of hurt. That's a big problem. If a blood clot has attached here and that thrombus breaks off, becomes an embolus, ends up in your heart, you can have a myocardial infarction. All right, so all these things caused from this atherosclerosis, right? And we see people that maybe eat a lot of saturated fat, they smoke, they don't exercise, they're overweight. There's a genetic factor. There are a lot of factors which contribute to someone developing atherosclerosis. In this atherosclerosis, development of these plaques can lead to a variety of diseases and syndromes in which we have a lot of drugs to try to counter the effects of these narrowed arteries. So, usually the first thing or drugs that people will be prescribed are cholesterol lowering medication. Let's start off by reducing the cholesterol in our blood. So hyperlipidemia, otherwise known as high cholesterol. So cholesterol and other plasma lipids, and when I say other plasma lipids, I'm talking about like the triglycerides, are carried in our blood and they're attached to proteins to make them more soluble in our plasma. And you've probably heard of these terms LDL and HDL. I think of the LDL as the lethal or the bad cholesterol, and the HDL or healthy is our good cholesterol. And sometimes through a variety of genetic factors, some people, we should have a balance between our LDL and HDL, but sometimes people have more LDLs than they're supposed to, or less HDLs than they're supposed to. Because essentially LDLs, the low density lipoproteins that carry the cholesterol, are very sticky and they stick to the inside of our vessels. Now the HDL, the high density lipoproteins, carry cholesterol that's actually good, and it actually cleans off, right? It removes the LDL from inside our vessels. So if we had a great perfect balance of those, we probably wouldn't have cholesterol problems, but most people, as they get older or they gain weight or their diet, they don't exercise, we can see this balance sort of tip. And I don't want you to think, oh my goodness, cholesterol is the worst thing in the whole wide world. Cholesterol is a necessary component of our body building cell membranes. So we do need cholesterol. Unfortunately, we end up consuming way more than we need. All right, and our liver is manufacturing this. So that's how the balance can get tipped out. So what is it? It's a waxy fat carried through the bloodstream by lipoproteins. So the high density or healthy density lipoproteins, those help clean out our vessels, deliver the LDLs, the lethal or low density lipoproteins, back to our liver. All right? So that's a good thing to know. The HDLs are our good ones and our LDLs are the ones. And here, target levels of cholesterol and triglycerides, just a different kind of lipid that is dissolved and carried through our system by proteins. So our total cholesterol, usually less than 200 milligrams per 1 deciliter. Now, if you are a previous survivor of a heart attack or stroke, sometimes this number can be moved to less than 150 milligrams per 1 deciliter. The LDLs are the lethal cholesterol. We want to see it less than 100 milligrams per deciliter. And the HDLs are the good cholesterol, 40 milligrams per deciliter or higher. So we want to see that good cholesterol be high. And our triglycerides, again, those are kind of considered unhealthy, less than 150 milligrams per deciliter. So antihyperlipidemic agents, these are cholesterol drugs. Every one of you, I bet almost every one of you, has seen someone in the clinic that is taking these drugs. So if someone has a high cholesterol count, they want to get in there and get that cholesterol lower, because if those LDLs are attaching into the inside of our blood vessels, we have a domino effect of having a whole host of other problems that is going to come along with it. So usually they're going to say, just like what we say, floss and brush, the doctor's going to say, lose weight, exercise more, eat less, exercise more, decrease that saturated fat and the cholesterol you consume in your diet. Drug therapy is usually aimed at lowering the level of the low-density lipoprotein, the LDLs. Some of the drugs are more specific for cholesterol and some are more specific to lower triglycerides. And these are our big ones. HMG CoA reductase inhibitors. So, reductase inhibitors, what does that mean? That means it's an enzyme. This drug is going to inhibit an enzyme. It inhibits the enzyme that converts saturated fat into cholesterol. It basically blocks the first step when the liver is synthesizing cholesterol. These drugs are often called statins. Don't confuse them with nystatin. Girl, and the drug companies calling a drug nystatin. That drug is older, but nystatin is an antifungal. It's the only drug that also ends in statin. That's not a cholesterol-lowering drug. So lovastatin, atorvastatin, all these drugs are an example of this HMG CoA reductase inhibitor. And they lower cholesterol levels. They inhibit this enzyme. And that blocks the first step in the liver's cholesterol synthesis. These drugs are some of the best drugs for getting someone's cholesterol back into a normal range. Some of the other drugs that we'll only touch upon lightly are older drugs, and they have found that these statins are much better at controlling or getting someone's cholesterol levels into a great range. They do have some adverse effects, and the biggest adverse effect that you're going to hear with these drugs is muscle pain. Now, I have so many muscle pains. I'm in pain right now from my workout. Patients that are taking these drugs are probably perhaps 40 years old and older. And when you get to a certain age, you have a lot of muscle pains anyway. So I'm not sure if it is statistically significant that the patients that are taking these drugs then say they have muscle pain. Whether these drugs actually cause the muscle pain or the person has some muscle pain and they say, this must be from my statin drug. I'm not really sure, but muscle pain's a big one. The other thing, this is a very serious, life-threatening problem that can occur with statin drugs. It's called rhabdomyolysis. It's usually seen when you combine a statin with another drug that we'll talk about in a couple of minutes. And this is basically the muscles in your body kind of melt. They break down. This is a little different than muscle pain. I mean, you would be in significant pain with this. And it is an exceptionally rare side effect, but it has been linked. They don't know what causes it. It has been linked to statin drugs. And statins also can increase the anticoagulant effect of warfarin. Now here's another drug, Zetia. This works by blocking the absorption of the cholesterol in the small intestine. It also works at reducing our triglycerides. So now these two drugs, the statins and Zetia, they work by two different ways. One of them blocks an enzyme, one of them blocks absorption. So they took these two drugs and they combined them into a drug called Vytorin. And Vytorin is basically the combination of those two drugs, Zetia and a statin. Unfortunately, this combination has been linked to that increased risk of rhabdomyolysis. So it's just something to be aware of. It's still pretty rare, but it can happen. And these drugs are drugs that are used probably less often, much less often. They use niacin sometimes, and we're not talking about the niacin that you're taking in your Centrum every day. This is a huge, huge dose of niacin. And they have found that it lowers cholesterol by inhibiting secretion of VLDLs, which is very low density lipoproteins. Funny side effect with niacin, it can make people really red in the face. It makes them flushed and hot and sweating. It's just one of the side effects. This other drug, cholestyramine, that binds to bile acids. And when you make bile acids insoluble products, bile acid, their formation is cholesterol forms bile acid. When you make bile acid insoluble, basically the cholesterol, instead of going into your arteries, starts forming more bile acids. And this is a fibrate, this next one, gemfibrozole, and that's used for lowering triglycerides. The one that I want you to be super familiar with are the statins. And this is just a nice little grid that I found on the internet that I like that talks about all the different anti-hyperlipidemic, the anti-cholesterol drugs. So what do we care about cholesterol? Well, we care about cholesterol as hygienists because patients that are taking anti-hyperlipidemic agents, basically they're at a higher risk for atherosclerosis and are at increased risk for cardiovascular emergencies. If someone's taking an anti-cholesterol medication, they've probably been found to have high cholesterol. So, probably if we looked inside their arteries, there was probably some plaque formation that's already happened. In fact, when a young person is killed in a traumatic accident or through an illness, when an autopsy has been performed, they have found right now that adolescents have plaque formation within their vessels. Whether it's a diet thing, we're all busy. I know last night, oh my goodness, let me have some mozzarella sticks. They're so delicious, but they're killing us. So pretty soon I'm probably going to be taking a statin too. Oops, wait a minute. Oops. Okay, perfect. Now, so we talked a little bit, okay, about the plaque formation causing blood clots. And I liked this little slide, hemostasis, life in the balance, right? So we have to balance between clotting to death and bleeding to death. Bleeding to death, trauma, major surgery, hemophilia, clotting to death, stroke, MI, thrombosis. So we're going to be kind of on this side, talking about drugs that try to prevent us from clotting to death. All right, and those drugs are known as anticoagulants. So these are drugs that interfere with coagulation. They're administered in an attempt to prevent clotting. So have that plaque, something, the blood platelets have attached to it, formed a clot. Once the clot is formed, an anticoagulant is not going to break it down. Anticoagulants only work against the formation of the clot. All right? They don't break up clots. We have different drugs for that. So, anticoagulants, if you have a deep vein thrombosis, you have a pulmonary embolism, myocardial infarction, or stroke, we're trying to prevent these things from happening. So hemostasis. Hemostasis is we are trying to halt or prevent the loss of blood after an injury to a blood vessel. So look at all these things, this clotting cascade, thromboplastin, factors 5, 7, and 10, and calcium ions form prothrombin, thrombin, and finally fibrinogen and fibrin. So that fibrin clot, that thing that kind of looks like a spider web, along with usually the vessel itself will kind of have some contractions, vascular spasms, shrink it up, platelets and red blood cells, quickly forms the clot so we don't bleed to death. Now, if the interior of a blood vessel remains smooth, circulating blood does not clot. It's that roughness from the plaque that can cause the platelets to stick to it. Many factors are required in the clotting process, and these factors are synthesized in our liver. Prothrombin, factors 7, 9, and 10 all require vitamin K for synthesis. And so here's a nice little image for you of the liver, vitamin K, synthesis of our coagulation factors. So intravascular clots can form in certain diseases. And these clots are called thrombus or thrombi. They can break off, and now they're called an embolus, and they can lodge in your heart, brain, and lungs. So anticoagulant therapy attempts to reduce this intravascular clotting. However, you have to be careful, because if the dose is too large, they can hemorrhage, and if the dose is too small, the person can't. So the first group of drugs that we're going to look at are drugs that interfere with clotting factors. So warfarin antagonizes the vitamin K that's necessary to synthesize 4 clotting factors that are produced by the liver, and this is how it produces its anticoagulant effect. The delay in return to normal clotting, it takes about 4 days for the person to begin to clot again normally. So if you're telling a patient not to take their warfarin or Coumadin prior to a dental appointment the day before, it's not going to work and it's dangerous. So they continue to take their warfarin or Coumadin, and we just go with their INR that we like to see between 2 and 3. And once it's between 2 and 3, we know they're safe to treat. And the principal adverse effect is hemorrhage after a mild trauma. Now, warfarin, we've talked about this in the past, and aspirin, they compete for the same plasma protein binding site. That's how the drugs are distributed in the body. They're either free or attached to plasma proteins. Aspirin's a bully. It kicks warfarin off. That means more warfarin's free to provide this effect, and guess what? A fatal hemorrhage can result. So we don't combine warfarin and aspirin together. And then warfarin, acetaminophen, except for combining it with alcohol, is usually pretty free of drug-drug interactions, although there was a study that did find a statistically significant association between acetaminophen, warfarin, and then an abnormal elevation of the INR. Warfarin and antibiotics. So antibiotics can potentiate the effect of warfarin because antibiotics reduce the bacterial flora that normally synthesize vitamin K in our gut. Warfarin also inhibits vitamin K, and then that's an added anticoagulant effect. This interaction, this isn't one dose of antibiotics that the person is taking if they need it for a dental cleaning. I'm not supposed to say cleaning, a prophylaxis or a dental appointment. This would be you are taking antibiotics for a couple of weeks. So we don't have to be so concerned if it's just for that one day. Heparin. Heparin is not something that we're going to see in the dental office. A patient, it's not used orally, it's only used IV. It's one of the most commonly used anticoagulant agents for a hospitalized patient. They get heparin, and it's administered parenterally. It can't be administered orally. And usually when a patient is in a hospital and they have heparin, they're probably also taking warfarin as well. So those are our drugs that interfere with our clotting factors that are synthesized in our liver. So we have another group of drugs, anticoagulants, that interfere with platelet, I called it stickiness, you could call it platelet aggregation. You know, platelets are sticky and we want to make them slipperier so they don't stick. So there are some drugs. Here's one, Ticlid. It reduces platelet aggregation. It's indicated to decrease thrombotic stroke in patients with a previous stroke. It's used in patients who are intolerant of aspirin. And don't combine this drug and NSAIDs because some stomach bleeding can occur. Because NSAIDs, remember, that caulks and it blocks the production of prostaglandins. But one of the good roles of prostaglandins is it helps make the mucus lining in our stomach. And NSAIDs will take that ability for us to make the mucus in our stomach away by blocking prostaglandin synthesis. And Plavix. Someone's had a recent MI or stroke, right? This also reduces platelet aggregation. But there's another drug, right, that's our best money saver that reduces platelet aggregation, makes them nice and sticky, and I want you to tell me. Those other two drugs that we talked about are big money, all right? What's another drug that's cheap that we can take to make our platelets slipperier? So these drugs, again, they do not dissolve clots. Those anticoagulants do not dissolve clots. They prevent clot formation. These drugs here are our clot busters. Now, you've probably, some of you maybe have heard of these drugs, especially TPA. Look at that, TPA. Where did we talk about that before? Oh, I remember. It's when our vessel has healed. The healed wall releases tissue plasminogen activator, right? Do you remember that? We have a drug called TPA that does the same thing. The healed wall breaks up the clot. This drug also breaks up the clot. These are enzymes, all right? And they promote the conversion of plasminogen to plasmid, which is our natural clot-resolving enzyme. So these are great drugs. And you know when they're used? Let's look at this. Someone reports to the hospital with symptoms of a stroke, and they sign a form. Do you want a clot buster drug? Now, there are two different kinds of strokes. There's a stroke it's an ischemic stroke caused by a thrombus that has let go and become an embolus. It has traveled to our brain. It ends up blocking blood flow to parts of our brain. Blocking that blood flow leads to ischemia, lack of oxygen. And there's also another kind of stroke, a hemorrhagic stroke. Someone has, maybe you've heard of something called an aneurysm. A cerebral aneurysm is a weakening in the blood vessel, can kind of balloon out. And then over time, especially if the person has high blood pressure, this weakening in the blood vessel can pop. And now blood starts filling up in the intracranial region, causing pressure, also causing cell death. Now, someone shows up to the emergency room, signs and symptoms of a stroke. 85+% of the time, it is an ischemic stroke caused from a thrombus that has let go, become an embolus, and lodged in the brain. In that circumstance, a clot-busting drug, such as TPA, can save their life. Okay? They have to sign a form that states that they can give that drug. Not only will it save their life, it can actually minimize the side effects that come after people have had a stroke. These people can have 100% full recovery. What's the downside? that 15% or less of the time, it could be a hemorrhagic stroke. They get a clot-busting drug, and that clot that is formed after the blood vessel has broken will dissolve, and the person will probably have a huge bleed in their brain, and it will kill them. So those are the tricky parts to this drug. It can be a miracle drug if you're having an ischemic stroke. It can be a deadly drug if you're having a hemorrhagic stroke. Now, the next thing we're going to talk about are arrhythmias. So why do we care about arrhythmias? We care about arrhythmias because depending on the arrhythmia that you have, you could actually end up forming clots within your atria. If the blood or the heart is not contracting properly, it allows, like think about blood all the time, moving. We don't want it to stop or slow down, because if it slows down, clots can form. So if your heart isn't contracting efficiently, blood can pool a little bit in the atria, and then it can form a clot, and then the ventricles will push that clot out into our systemic circulation, and it can end up going to your brain. So what is an arrhythmia? Let's look here. Basically, it's an abnormal electrical conduction within the heart, and the heart isn't contracting properly. It's usually caused by some sort of lack of oxygen to the cardiac muscle itself. It can happen. So cells of cardiac muscles have an intrinsic rhythm, and that intrinsic rhythm is referred to as automaticity. And the rhythm is led by the SA node. The SA node acts sort of like the conductor, and it tells all the other cells of the heart how and when to contract so that it stays organized. We need 2 organized contractions within our heart. We don't want all one big one contraction. We need to contract the atria, have a break, then contract the ventricles. That break allows the blood to flow into the ventricles and fill the ventricles fully, and then we have a nice good contraction which pushes the blood out so that it can go to the rest of our body. So the SA node has the fastest rate of depolarization. So the SA node depolarizes, sends the message to the AV node, which then goes to the bundle of His, the Purkinje fibers, and then the ventricles. Signals from the SA node tell the atria to contract. Then the signal travels to the AV node, and the AV node triggers the ventricles to contract. So arrhythmias, you may hear of arrhythmias called atrial arrhythmias, ventricle arrhythmias. There's also something called a supraventricular arrhythmia. Supra, above, ventricular, above the ventricles, is just another fancy way to say atrial arrhythmias. And so we have drugs, and we have drugs that can treat arrhythmias. And they're placed into 4 groups designated by numerals 1 through 4 according to their mechanism of action. So what's the goal when you give someone an antiarrhythmic agent? It's to prevent repolarization or depolarization or repolarization, or delay it so that the muscle cells won't contract by themselves, but they'll be directed by the SA node or the AV node. Antiarrhythmic agents work by depressing parts of the heart that are beating abnormally. So they can decrease the rate of depolarization, they can decrease the impulse message, they inhibit impulse propagation from different areas of the heart. Sometimes different areas of the heart decide that they're going to take over and try to control the heartbeat, and that doesn't work. The SA node has to be the conductor, and we always want the SA node to be in charge. And just one more thing about arrhythmias. So we had spoken, or I talked about that arrhythmias can be atrial. So we've heard of atrial fibrillation. They can also occur in the ventricles. Atrial fibrillation is the one you can see with clots formation. If you have atrial fibrillation, that's an arrhythmia. The other kind of arrhythmia that can happen is something called ventricle fibrillation. Ventricle fibrillation, now we need that ventricle to get a good squeeze, a good contraction to get the blood out everywhere. When a ventricle fibrillation is happening, the heart looks like, I don't know, a sack of snakes. There's no good double contraction. It's like just all over the place. That is a life-threatening emergency, a ventricular fibrillation. And there are things that they could do to treat that, and probably drugs might be part of it, but there are things that they can implant within your body if you have ventricular fibrillation a lot. But let's talk about the antiarrhythmic agents, the drugs. So we have sodium channel blockers. So the sodium influx, we've talked about these drugs, right? Lidocaine blocks sodium influx, right? It slows depolarization. So if the heart is beating out of sync too fast, these sodium channel blockers, lidocaine, you talk to a hygienist, you say lidocaine, they think I'm getting that person numb. You talk about it in an emergency room, and they're thinking about treating an arrhythmia. And these are the two drugs that can treat arrhythmias within the heart. So they are a class 1. Class 2, beta blockers. So beta blockers, we know that they can slow the heart down, right? They're sympatholytics. So they decrease the sympathetic effects on the SA node, and they slow the heart down. And that drug is propranolol. That is a non-selective beta blocker. And then we have potassium channel blockers. They delay repolarization by preventing potassium from moving out of the cell. Now, some of these drugs, such as amiodarone here, antiarrhythmics have a very narrow therapeutic index. You don't want to delay repolarization too much or slow things down too much, because then all of a sudden the heart isn't functioning as well, or it's not beating the way it should. So antiarrhythmics are really tricky with dosing and getting the effect that you want, which is to make the SA node the conductor to get those two good contractions. So this one is a little tricky, this kind of drug, because you don't want to delay it too much. And then lastly, calcium channel blocker. So calcium depolarizes the membrane at the AV node. With the blocker in place, there's a delayed depolarization. And we'll talk more about these drugs, verapamil, nifedipine, diltiazem, at our next class as well. So these drugs can all be used as antiarrhythmics. So I already spoke about this. Antiarrhythmic agents, super narrow therapeutic index, they're really difficult to manage. If someone is you don't want to fool around with the heart. We have to have good beats. We don't want clots to form, and we want to get all of our tissues perfused with oxygen-rich blood. So if the drugs are not working, or if the arrhythmia is significant enough, you're having a lot of problems with bradycardia or tachycardia, you may have something implanted, such as a pacemaker, to help control your heart rate. The other thing, if you are suffering from ventricular fibrillation a lot, they are going to implant something called an ICD, which is an implanted cardioverter defibrillator. It's a defibrillator that if it senses that your heart is going into fibrillation, ventricular fibrillation, it's going to send a shock to your heart to get the rhythm back. All right, and that is our lecture, the first part of cardiac drugs.